start, probably?
Yes.
Okay, so welcome everyone to this new edition of Fujita Alumni Association Batane Hospital webinar series. Today, well, first of all, of course, I want to, as usual, I want to welcome Professor Yoko Kato, our mentor, and my co-moderator, Ishu Bishnoi. Thank you for being here, and thank you also to all the many friends I see connected, Sachin, Liu, Raja, see Ricardo, Professor Pizad, Kapil. So thank you, all of you. And a special thank you to our speakers today. We have two very, very interesting talks. The first speaker is Professor Rokuya Tanikawa, who does not need any long introduction. He is very well known worldwide. He is executive vice president and director of the Department of Neurosurgery, Stroke Center in Sapporo Eishinkai Hospital in Japan. And our second speaker is Dr. Kento Sasaki. He is a senior resident and assistant professor at the Department of Neurosurgery at the Fujita Medical University Batane Hospital in Nagoya, Japan. So, Professor Yoko Kato, do you want to say some introductory words before I introduce our first speaker?
Thank you. Thanks so much. So hello everyone, and thank you very much. Especially, I really thank you very much, Roku Tanikawa Sensei. He's so busy man, but even such a situation that he accepted. Once I asked him, then 30 minutes after he said, okay. So he's really famous, the super expert of especially the vascular. Maybe he is maybe one of the top. Maybe no need to say the one of the top. Maybe I think top vascular neurosurgeon in the world. I think so. We are so lucky to receive him. And second one is my senior. So maybe you can listen to his lecture afterward. Thank you very much.
Thank you very much, Professor Yoko Kato. So I would like to invite our first speaker, Professor Tanikawa, to start his presentation about vascular reconstructions and microsurgical approach. So, Professor.
Okay. Thank you very much, Professor Yoko Kato, and everybody to Fujita Alumni Association webinar. It's my honor to share my experience, and it's not a problem to be asked suddenly, no problem. It's my pleasure. Today, I will show you vascular reconstructions and microsurgical approach to cerebral aneurysm treatment. Can you see my screen?
Yes.
Okay. So I'll start my presentation. Everybody knows that distal transribbian approach or transribbian approach is a very basic approach to any lesions, intracranial lesions. This is an example of a 57-year-old female previously treated the left side MCA and carotid aneurysm. This time, the right side small basilar supracerebral artery aneurysm is being treated. Now, in the right front temporal craniotomy, the distal transribbian approach being performed. Here, this is a very hypertrophic arachnoid trabeculae can be seen, and MCA bifurcation is exposed in the cerebral fissure. The gradually superficial part and the middle part of cerebral fissure, which the temporal and the frontal lobe are adherent so much. But with the highest magnification and the bloodless operative field can provide a very good view what we should separate, what we should cut insides. And now from MCA bifurcation to internal carotid, all the view is exposed, and this is a dissection of inferior trunk of M2 and anterior temporal artery from the inner surface of a temporal lobe, and the brain spatula is placed on the temporal uncus, and anterior choroidal artery is separated from the temporal uncus. In the depths, you can see the cisternal oculomotor nerve, and the lateral part of lyricus membrane lateral to oculomotor nerve can be insides, and you can expose the supracerebral artery. And the medial lyricus membrane is hiding the aneurysm itself here, and the aneurysm is exposed by opening a lyricus membrane. Additionally, the very tiny perforator just beside the aneurysm could be seen. The proximal control on the basal trunk is performed. And now, with the highest magnification, you can confirm the tip of a clip and place the clip on the neck, not to bite the important perforators beside the aneurysm or behind the aneurysm. And the anterior remnant of the aneurysm could be occluded with fenestrated mini clips. And now again, you can confirm that all the structures are preserved. And the post-operative CT angio, this is a posterior view, and immediate after the surgery, that we can check the CT scan. The patient had nothing, no neurological deficit. Another case, another approach, the anti-in-time scar approach is important approach. This is a case of subarachnoid hemorrhage, ruptured one, the large acom aneurysm. The diameter is approximately 15 millimeter in the most largest part. Here, the superficial arachnoid membrane and the anterior internal hemisphere fissure could be separated, and gradually the callous marginal pericarosal arteries can be exposed with a meticulous dissection with a repeated irrigation, repeated rinsing of subarachnoid clot. And now here, this is a bilateral pericarosal arteries in the pericarosal system. At this moment, the first step of the interhemisphere approach is completed, and you can recognize a small triangle in the base of an operative field. Here, at the top of the triangle, you can recognize the tiny trabeculae connecting both singular gyruses. You can incise only this arachnoid trabecula, and beyond the arachnoid trabecula, you can find the space. I call this space perivascular system. Now again, in the depths, the small triangle appears again and again. The small triangles can be extended superiorly by incising the arachnoid trabeculae in between the bilateral singular gyruses like this. then you can recognize the perivascular system here. This is the origin of cross marginal artery, and gradually you can approach to the aneurysm and proximal parent artery. Left A1 in this case is dominant, and the temporal clip is placed at the distal of left A1. And then after detaching aneurysm, which was embedding in the right cingulate gyrus, is dug out, and right A1 and the bilateral A2 is occluded to decompress the aneurysm completely. Then you can try to do a neck plastic aneurysm clipping. In such large aneurysms, not only in ACOM aneurysm, the fenestrated clips are very useful and effective to reconstruct the aneurysm neck and to preserve the parent arteries. This technique, the using multiple fenestrated clips, it's a very famous technique, especially Professor Yoko Kato and Professor Tasano. They have already developed so long time ago when I was a resident. I watched such a technique in a neurosurgical meeting when I was young guy. I learned a lot how much such a multiple fenestrated clip applying is necessary and effective in complex aneurysm surgery. Whatever we try to do such a special techniques, special surgeries. When we perform the surgeries, the clean operative field, bloodless operative field is very important. It's necessary, especially the hemostasis in every step from the skin incision, after skin incision, the muscular incision or muscular detachment from the bone, and in a craniotomy, the cutting edge of the bone has always bleeding from the diploic veins or oozing from the bony surface. Dural hemostasis, the space between the bone and the dural surface has always bleeding, not only arterial bleeding, but also venous oozing from the inner plate of a skull. So such a hemostasis is very important. And I always emphasize that before opening dura, you need to get the complete hemostasis completely. Otherwise, the epidural bleeding, epidural oozing or oozing from the skin is coming into operative field subdurally. Then it disturbs you when you want to confirm the precise anatomy when you are trying to do a clipping or something, or the vascular reconstructions. All the bleeding always disturbs your precise manipulation. Now again, interhemispheric feature approach dissection is very useful, especially to clip the complex large giant ACOM aneurysms. Additionally, we can perform the revascularization immediately after something accidental parent artery occlusion of anterior cerebral artery territory happens. You can immediately perform the A3, or A4, A2, side-to-side anastomosis, something. As well, I always emphasize the dural closure, watertight dural closure. I force my young colleagues to close the dura watertightly under microscope meticulously. This is quite important. This is quite important. And this is a very good training for microvascular anastomosis. My mentor, Professor Kamiyama, always told us 30 years ago that a neurosurgeon who cannot close the dura watertightly cannot perform the precise, exact microanastomosis. That's true. So every neurosurgeon, young resident who wish to be a cerebrovascular surgeon, must close the dura watertightly every day in a daily surgery. In vascular anastomosis, especially microanastomosis, this is important two principles. One is a Fishman streaming at the donor when you perform the side-to-end anastomosis. And another one is everting of both vessels of the donor and the recipient must be attached intima to intima. These are the important principle. And the stitching bite in the microanastomosis, not only in the microanastomosis, but also at the large anastomosis, anything. The stitching bite should be twice of the wall thickness, and the stitching interval should be 4 times of wall thickness, like this. With the stitching, in general, you don't need to see the leakage in between the intervals, stitch intervals. The picture drawn by my colleague Cosmo Noda, when we perform the end-to-side anastomosis, if you once make the condition of everting like this, you can penetrate both vessel wall with one action with the appropriate counter force to the other side. It's a very important technique. And when we perform the side-to-side anastomosis like A3, this is a picture Professor Kamiyama drawn more than 30 years ago. The inner symmetrical curved incision should be performed bilaterally like this. Then the bottom side suture should be the running continuous suture, and the superior wall could be occluded with could be stitched with interrupted suture. I'll show you an example of a retrograde suction decompression technique for giant internal carotid, the paracranial segment aneurysm. In this case, firstly, the suprathyroid artery is cannulated. The tip of the cannulation should be placed in a common carotid artery, and superficial M4 bypass on the temporal side is being performed now in order to ensure the backup during temporal occlusion of internal carotid, or in case of something occlusion of parent artery, or after clipping something, you can compensate the blood flow to a distal MCA and the ACA territory through the STA during solving the problem. Anyway, in the neck, the external carotid and the common carotid is occluded, and blood in the internal carotid and the aneurysm could be sucked through the suprathyroid. And then now you can see the compressed elevated left optic nerve is decompressed by the retrograde suction decompression. This is an incision of a distal dural ring. The lateral inferior part is inside, and partially the cavernous sinus is open. And the superior part of a distal dural ring as well, inside, and you can see the origin of ophthalmic artery could be seen. Now, this condition, so you can try to place the clips as a neck clipping like this. Now, the common carotid can be opened, and the distal internal carotid occlusion is as well opened. And now the blood flow is coming to the brain. But at this moment, I have a doubt that the aneurysm still is alive. Partially has a aneurysm has a thrombus inside, and you can see the slow arterial bleeding is coming. This means that the medial thin part of aneurysm is not occluded completely. So, as I told you in the previous video, the fenestrated clips, in this case, the large straight fenestrated clip could be placed to occlude the medial thin part of the aneurysm. Then, aneurysm completely occluded. The postoperative CT scan shows very good patency of ICA, and brain condition is good. The patient had a visual disturbance preoperatively, but after surgery, the immediately patient visual acuity recovered. I'll show you the anterotemporal approach, modified Trans-Sylvian approach to the distal basilar aneurysm. Sometimes we need to elevate the dura propria from the lateral cavernous sinus wall. After elevating dura propria like this, you can expose the third nerve, fourth nerve, V1 and V2, and we can recognize important anatomical landmarks. In between V1 and V2, there is an anterolateral triangle, foramen rotundum. Lateral to V2, you can find a far lateral triangle, so-called lateral loop. And you can recognize the oculomotor foramen like this. And in between third nerve and the fourth nerve, there is a superior triangle. And here is a Parkinson triangle in between fourth nerve and V1. By elevating dura propria like this without antecrinoidectomy, you can detach the double layer of tentorial edge. Then you can extend the retrocarotid space inferiorly. This is an example of a 79-year-old female. Relatively large right side basilar superior cerebral artery aneurysm. In this case, the aneurysm has a high position, so the zygomectomy has performed only zygomatic arch, not orbitozygomatic. And in this case, the dura propria is elevated from lateral cavernous sinus wall, and the anteroclinoid process is preserved. And intradural Trans-Sylvian anterotemporal approach is being performed. And frontal side, the dura is incised toward the tentorial edge along the lateral margin of anteroclinoid process. Then you can get a complete hemostasis from the lateral cavernous sinus wall. And oculomotor foramen is being opened, and Fosner, pores trochlearis, and the the cavernous segment fourth nerve is being dissected in order to mobilize the fourth nerve from the cavernous sinus wall. Because in this case, the basilar artery is very tortuous, not coming up straightly. So the basilar artery is coming from the contralateral to the ipsilateral in a pluripontine system. So the extending the retrocarotid space inferiorly by mobilizing the fourth nerve with opening of pores trochlearis, you can extend the base side operative field, the inferior to a fourth nerve. So the opening of Parkinson triangle is necessary in this case as well. The oculomotor filament should be opened completely, and the cisternar oculomotor nerve should be dissected as well, like this, and get a hemostasis if you have a bleeding from a cavernous sinus. Anyway, the third nerve and the fourth nerve is being dissected completely from the cavernous sinus wall, and now the bleeding from cavernous sinus can be stopped with a fibrin-soaked gel form like this. Now you can see this white triangle is an extended Parkinson triangle. Then you can see the basilar trunk very obliquely coming toward the distal part of the basilar artery. After opening the Parkinson triangle, in the depths, you can find the Groover's ligament and the opening of inferior petrosal sinus, just medial to the sixth nerve. And the cavernous sinus and the inferior petrosal nerve, inferior petrosal sinus could be get a hemostasis with the gel form. And now you can see the proximal basilar could be controlled without any stress to a cranial nerve. At this moment, after temporal occlusion of a basilar artery, the aneurysm could be decompressed sufficiently to detach the strong adhesion of oculomotor nerve to the dome. The proximal dome has atherosclerotic, and you can confirm the supracerebral artery as well. And here, I am trying to place the clip appropriately to occlude the neck, not to occlude the important perforators, which is coming down from the basilar bifurcation behind the aneurysm. You can see that these perforators are the perforators from basilar bifurcation coming down, because in this case, basilar bifurcation is in a high position. High position basilar bifurcation always has the perforators. Those perforators must come down toward the interpeduncular system to the midbrain. Anyway, after complete neck clipping, you can confirm here the basilar bifurcation, contralateral P1 and the ipsilateral P1 and mammillary body could be seen. And this is a dural closure after manipulation subdurally, and watertight dural closure is performed. This is the final view. And CT scan and the CT angio shows a complete obliteration of aneurysm. This is an illustration what we did in this operation. The key was in this operation is opening oculomotor filament opening fourth trochlearis, the fourth nerve foramen, and opening the Parkinson triangle with confirming the inferior pituitary sinus outlet, which is outlet of a Doraros canal. And posteromedially, there is a Gruber's ligament. Those anatomy is very important, not only in tumor surgery, cavernous meningioma surgery, but also cerebral vascular surgery, especially for distal basal aneurysm cripping. I think it's a time to finish, so I skipped this. So in conclusion, I recommend these principles.
Maybe Tanikawa Sensei.
Hi.
Can you show us the short time of the bypass surgery, please? Do not need to skip. Just show us the short time of the bypass surgery, please.
Yeah, I have. Okay. I have a. So I'll show you this one. This is a 43-year-old female, previously clipped 7 years ago. Previous clipped aneurysm, large MCA aneurysm. Unfortunately, she had a recurrence. So she referred to us, and we tried to treat this aneurysm. Here is the recurrent part, and these are the previous clips. So many clips. You can see the so strong adhesion and granulations on the aneurysm and the parent arteries. The difficult point in this case, the intermediate M2 arises from aneurysm itself. So the superficial temporal artery was still preserved. So I tried to do a superficial temporal artery to intermediate M2 pipe branch first. Now you can see the intermediate branch is revascularized. Then we can separate the origin of this artery from the aneurysm. Now this is the intermediate branch is dissected, and the temporal clip is placed on the intermediate branch origin. Then it can be separated from the aneurysm. I made a fishbone trimming at the cutting edge of the intermediate branch, and it is made as a transposition to the supra trunk of M2, just next to the intermediate branch. So you can understand that superficial temporal artery can vascularize the intermediate branch and supra trunk of M2. So during neck clipping, you can occlude the supra trunk if necessary. But now I am trying to dissect all the parent artery, and during dissection, the origin of a supra trunk is injured. At this moment, I try to repair the laceration of the supra trunk of M2 and continue the dissection of the aneurysm completely. And I am trying to remove the previous clips completely. All the previous clips must be removed. At this moment, inferior trunk of M2 has not been revascularized because there were just one branch of the superficial temporal artery. So we are monitoring the MEP. Fortunately, nothing happened in this temporary occlusion of aneurysm M1 and the inferior trunk of M2. But fortunately, like this, the aneurysm could be clipped as a net clipping like this. The remaining part, inferolateral part of the aneurysm, the remnant, could be occluded with a multiple clipping technique with the fenestrated clips like this. And fortunately, the super trunk could be saved as well, like this. So CT angio immediately after surgery shows a good patency of all the parent arteries and revascularization. The operation, what we did in this surgery is like this. The first clip is large one, and second clip is a large fenestrated clip like this. And additionally, the third clip is placed like this to occlude the remnant. And additionally, this part is occluded with the fourth and the fifth clips. Anyway, this is a very complex surgery, but with a step-by-step, the meticulous dissection, complete exposure, complete dissection of granulation, even after the surgery and recurrence, we can try to expose the lesion completely. Then we can perform the revascularization. It's simple. Just the STA M2 bypass, and the revascularized M2 can be transposed to the next artery. So in conclusion, we can do the precise exact surgery with a clean and a bright operative field with highest magnification of microscope. And the hemostasis in every step can provide a beautiful, clean operative field. And we can separate the sylvian fissure or interhemispheric fissure by cutting the only arachnoid membrane or trabeculus. And all the cerebral vein must be preserved. Of course, in some condition, that we need to sacrifice something, but it's always neurosurgeon is always responsible to sacrifice anything. So that at firstly, we should try to preserve everything. In very limited condition, we can sacrifice. And this sylvian separation is a basis of a microsurgery. This is a very fundamental skill. So as a first training for young guys, the separation of a sylvian fissure bloodlessly, with this accumulation of the experience, then gradually you can achieve the skill of a microanastomosis. The watertight dural closure every day, daily life, helps you to perform the exact microanastomosis. Please be careful to perform the dural closure watertightly. This is a key. This is a key for the exact surgery, not only microanastomosis. That's all. Thank you very much.
Thank you very much, Professor Tanikawa, for this excellent presentation. Well, it's always difficult to say something after your speeches because you show so complex surgery performed in a perfect way. So thank you very much. I think you showed us how nicely it is possible to match vascular neurosurgery with skull base. surgery in some cases. And I really appreciated the final recommendations for young neurosurgeons. I think young people need to have some clear basis from where to move on to achieve good results. So I would like to open the discussion at this point. If there are some questions for Professor Tanikawa, please. It is a good moment.
Maybe Ashish is one of the commentators. Ashish?
Thank you, Professor Caro.
Yes.
Thanks, Alberto. Professor Tanikawa, it was a pleasure watching your skills especially in ruptured cases. And I am currently at the University of Toronto, and because I have been trained at Fujita Health University in the past few years, I know the extent on and the kind of microdissection done as the Japanese centers. I just wanted to ask about, because we frequently have a debate about the use of retractors in ruptured subarachnoid cases, especially for young neurosurgeons. What's your recommendation in using the fixed retractor system? And the second question I would like to ask is about the sharp and blunt dissection around the aneurysm. What's your preference about a sharp or a blunt dissection around the aneurysm?
Yeah, it's a very important point to dissect the aneurysm sharply or bluntly. It depends on the situation. The sharp dissection or blunt dissection is dangerous, especially in a very thin wall dissection of the aneurysm or ruptured point to dissect. So the key is regardless you try to do a sharp or blunt dissection, especially in a dangerous spot, I recommend young guys every day use the highest magnification and see the dissecting plane exactly, and whether the blunt dissection is tolerable to the target which is dissected. Blunt dissection means that the dissected plane is made not by your intention. The weakest part is dissected by blunt dissection, but sharp dissection makes the plane you intended. You see? So in this standpoint, you can say that you can understand the sharp dissection is safer than blunt dissection because you can control. So what I mean, the highest magnification and observe the dissecting plane carefully, then you can understand where is safest point to cut. You see? So I always recommend young guys sharp dissection. Try to do sharply, fastly. But when I was young, my mentor, the senior, the neurosurgeons always told the young guys, "Oh no, don't do too much high magnification. Don't be close to the aneurysm. It's dangerous." But it's wrong. To see the dangerous spot carefully, because the part is dangerous, you need to observe the dangerous spot carefully. This is a key. This is a principle. You see. So the lowest magnification does not work at all. we need to familiar to use the highest magnification. Even the highest magnification was too much power, you can reduce the magnification in the middle, it works. Anyway, we need to confirm the dissecting plane. Where is dangerous? Where is the most dangerous part? You see, this is a point.
Thank you so much. And the use of retractors, what is your suggestion?
Yeah.
Fixed
Retractors.
versus dynamic retraction, Professor Tanikawa. Which do you prefer and when?
I prefer to use a brain retractor, but the term of a retractor, the term as a retractor is not appropriate, I think. The retractor is not my meaning. The brain retractor does not retract the brain, just hold brain very gently, very softly, not to compress the brain too much. And V-shaped brain compression is terrible. It's too much. Such a condition should not be performed. We should avoid such a condition. If the brain is very swollen in acute subarachnoid hemorrhage, we need to make the brain slack with ventricular drainage or cisterna drainage. And if the anesthesia was not appropriate, ask anesthesiologist to reduce the blood CO2 level around less than 30 millimercury to 25 millimercury, and we can wait to brain become stuck. Then gradually you can open the fissure, and then you can get the CSF draining out. Then gradually brain become stuck, even in acute stage surgery. Of course, the very high-grade subarachnoid hemorrhage patient has a continuous swelling brain. But in my experience, such a swollen brain in a high-grade patient, unfortunately, is not a surgical indication. The surgical indication was wrong in such a patient. But in almost patient, we try to do operation that we can control the brain swelling with appropriate drainage or the appropriate anesthesia control. It's my opinion.
Thank you so much. Anyone else, Alberto, would like to ask questions to Professor Tanikawa?
Yeah, thank you. Thank you, Professor, for such a wonderful talk. And my question is, like, if you are getting grade 4, grade 5 subarachnoid hemorrhage, Hunt and Hess, do you prefer to do in same grading, or you wait for improvement in the grading? Like if they become conscious, or at least there is some improvement in consciousness. How do you proceed?
Yeah, it's a good point. We do immediately. We do a very ultra fast surgery. Our rule in our institute is the patient who has a surgical indication must be transferred to OR within 1 hour after arrival.
So next question is, like, in such cases, in such kind of cases, like, have you ever faced delayed cerebral ischemia? Like the surgery was all good and the patient was coming out, but after 7-10 days, because usually these patients, they develop those kind of neurogenic pulmonary edema or stunned myocardium or delayed cerebral ischemia. So how's your experience regarding their morbidity and mortality?
Yeah, in our experience, even the grade 5, grade 4 patient, around the 10% in a grade 5 patient, 10% patient can be recovered with a good recovery. Grade 4 patient recovers around 40% for the good recovery with ultra-early surgery. So in our experience, I can say that the reason why the brain condition is worse in a high-grade patient is elevating the intracranial pressure due to a ruptured aneurysm, the thick subarachnoid clot blocking the CSF the circulation, and of course the high intracranial pressure causes the brain circulation, especially venous circulation. So to reduce such a bad condition with early craniotomy and early dural opening, early wide cisternal opening, and the removal of the subarachnoid clot, rinsing subarachnoid clot in major cistern, it's very helpful to the patient brain condition recovery. And we usually perform for example, in anterior circulation, like internal carotid, MCA, or distal basilar aneurysm, ACOM aneurysm, when we perform the transribian approach, we do a contralateral transribian opening through the prechiasmatic cistern, and the contralateral cerebral fissure clot is evacuated, and if necessary, we can open the proximal interhemiscus fissure in a subfrontal approach. And in an interhemiscus approach for ACOM aneurysm, after clipping of ACOM aneurysm through the interhemiscus approach, we try to open the bilateral cerebral fissure frontal basal approach. Then open the bilateral cerebral fissure toward the basal system to confirm the basilar arteries from both sides, and the rinsing the clot completely. Then we can have the very low rate of the delayed vasospasm around 4%. Okay. Overall result is 4%. Most recent result is 5%, a bit higher, 5%. Anyway, in this 10 years, around 270 cases, the delayed vasospasm is around 5%, with a very ultra early surgery.
That's very good. And sir, do you prefer watertight dura closure in grade 4 and 5 cases? Because generally neurosurgeons, they fear that the cerebral edema can increase and they might develop infarct. So like my tendency is to leave the dura open in grade 4 and 5 cases after doing surgery. So,
when we try to close the head, we need to confirm the brain condition. If the brain condition is swollen, we do not close the dura tightly, of course. We need a decompression with the craniectomy. Yeah. But if the brain condition recovered very slack, you need to close the dura water tightly completely. More than 95 cases of cerebral hemorrhage in our institute, every patient brain condition becomes slack. So we need to close the dura water tightly in almost cases.
Thank you, Professor. Thank you so much.
Yeah. Welcome.
Professor, I also have a couple of questions. So, as you mentioned, sometimes we have to release the pressure, releasing CSF. Of course, preferably from the cisterns, but sometimes we need to release CSF from ventricles. So, my first question is, what's your preferred technique? Do you place lumbar drainage, as some people do, or do you use the page point intraoperatively to place an EVD, or how do you manage ventricular drainage? And the second question the second question is about the ACOM aneurysms. Do you usually prefer the interhemispheric approach, or do you sometimes use the pterional approach? And if so, how do you choose between these two approaches for anterior communicating aneurysms? Thank you.
Okay. The ventricular drainage is my preference during craniotomy. Actually, after making the big craniotomy, right or left in anterior circulation, then simultaneously I make the classical point of backhaul here, the 3 centimeter anterior to bregma, the 3 centimeter lateral from the midline. In a classical point, I make a one backhaul, and put the ventricular drainage in anterior horn, and then make a big craniotomy. Then you can get the slack brain before opening dura. This is the first choice. And secondly, we open the Sylvian fissure and open the Sylvian fissure toward the carotid system. Then usually, when we open the carotid system, the CSF is coming very well, very much. Then the brain becomes slack. Even if in some patients through the classical point ventricular drainage was very difficult or impossible. In such case, you can open the lyricus, lamina terminalis just above the chiasma. Then you can drainage the CSF through the third ventricle. I never use the lumbar drainage before surgery because with high pressure of intracranial high pressure, it may causes the lumbar drainage may cause something herniation, tonsillar herniation, something. I'm afraid of that. So especially if the aqueduct or third ventricle was blocked with a thick interventricular clot, the lumbar drainage spinal drainage is not appropriate. So I don't use it. I never use it. I prefer ventricular drainage. And anterior interhemispheric approach and pterional approach, the selection is important. We have a much discussion about it. But basically, we prefer interhemispheric approach for ACOM aneurysm, basically. But if patients have the multiple aneurysm with carotid or MCA and ACOM aneurysm, we try to do a pterional approach. And we try to grip the both aneurysms through the pterional. But if just a single ACOM aneurysm, basically we choose the anterior interhemispheric approach.
Thank you, Professor.
Yeah.
Thank you very much. So,
Professor Tanikawa, yes, I just wanted to have one last question.
Go ahead.
Especially for young neurosurgeons, what's your philosophy for using the temporary clip? How frequent you use it? Do you use it intermittently? Do you use it when you are close to the aneurysm? If you can just expand on the use of temporary clipping in ruptured cases, especially.
Yeah, in a ruptured case, basically, I always use a temporary clip, always, to reduce the tension of aneurysm. Decompression of aneurysm is the safest way to perform the neck clipping safely. But it depends on the condition of the parent artery. If the parent artery has a very thick atherosclerotic change with a yellow plaque or calcification, never use a temporal grape on such the dangerous part. Especially in the internal carotid aneurysm, the temporary proximal occlusion is very effective, and it is the safest way. But if the carotid often have the atherosclerotic change, so in such case, I always open neck, and I perform the proximal control at common carotid and external carotid simultaneously. Then you can have the a very good decompression. Because I have a very bad experience of internal carotid occlusion spontaneously immediately after temporal clipping on the supracranial carotid. That was an unruptured case. When the neurosurgeon in my institute tried to do the PCOM aneurysm with a very strong atherosclerotic change of a supracranial segment. At the time, in OR, I advised him not to press a temporal clip there. That part has a very yellowish atherosclerotic change. It's dangerous, but he didn't follow me. He pressed a temporal clip, then clipping safely performed, but after removal, the carotid occluded. In the case, we had to do emergent high flow bypass in between the external carotid and MCA because the carotid was not opened. So, if such a complication happens, yeah, of course, patient is very patient in the strong trouble, but as well as the surgeons are very busy, and our mentality becomes so bad during surgery, you see. So I want to avoid such a circumstances. So I recommend, if there is a hard atherosclerotic change on the parent artery, any part, don't put the temporal clip in such a part. You need to looking for the safe part without atherosclerotic change, without calcification, without plaques. That's my philosophy.
Thank you. And how long is your temporary clipping?
Depends on the situation. The meaning of situation is the collateral flow. Of course, we can confirm the how good collateral is coming before surgery in angiography, but sometimes the evaluation preoperatively is not possible. In such case, when you put the temporal clip, if you can perform the MEP monitoring or SEP monitoring, if the MEP or SEP disappeared, immediately you should remove the temporal clip. Depend on the patient, depend on the collateralist. It's tolerate 5 minutes, 10 minutes, 15 minutes, depends on. So the best way is monitoring MEP and SEP simultaneously, both. But at least we need the either one during especially internal carotid and MCA surgery. I recommend it. But in emergency surgery, especially midnight or not only midnight, after 5 p.m., the intraoperative EEG monitoring is not available. So in such case, the temporary occlusion time should be as short as possible. Less than 5 minutes.
Thank you so much.
Thank you. Ashish, I think we have two raised hands.
Yes.
Kapil
Dr.
first.
Kapil.
Yeah. So thank you for such a elaborate explanation of all the aneurysm surgeries and what a complex aneurysm we can treat with by surgical management. So I would like to know where we can place, means you as your expert opinion can place the IVR treatment in such aneurysms. Means which aneurysms we absolutely should consider for an IVR in your experience, where you place the IVR treatment in aneurysm surgeries. Treatment of aneurysm.
IVR means that endovascular?
Yes, endovascular.
Endovascular. Yeah, that's a good question. Basically, we choose endovascular treatment for mid-basilar aneurysm. Mid-basilar aneurysm. For example, a basilar ICA or lower basilar aneurysm, where is very difficult to approach, especially in acute subarachnoid hemorrhage. It's too invasive to approach. For such aneurysm, we choose the endovascular treatment, coiling. But as I showed you, the distal basilar aneurysm and anterior circulation can be approached safely even in subarachnoid hemorrhage. So we try to do a neck clipping.
Yes, thank you, sir.
Thank you. Issue, did you had a question? Unmute.
It was by mistake. Yeah.
Okay, good. So I see.
Tanikawa-sensei, thank you very much. So what about the paraclinoid aneurysm? What is your concept for the any space for endovascular treatment?
Especially unruptured, the paraclinoid is almost paraclinoid is the unruptured cases, and in this 10 years, especially early 5-6 years in this 10 years, we try to do a neck clipping so much, more than 250 cases. The bad thing, unfortunately, we had a so high rate of the visual disturbance after the anticlinoidectomy and the clipping. 20% of a visual disturbance, something happens, visual disturbance, 20%. And 6% of them had blindness, especially the immediately after surgery, those patients has a good visual acuity. We can confirm with the patient and the patient family, but around 36 or 48 hours later after surgery, suddenly patient visual acuity lost. It's a 6%. And the cause of the blindness cannot be detected exactly now, even now. There are many discussions in our institute, something mechanical stress or the venous drainage congestion or the arterial ischemia, delayed ischemia, something. But the point is immediately after surgery, around more than 24 hours, the patient has a good visual acuity. But around the 36 or 48 hours, the patient lost. So some pathophysiological changes happening after surgery, after anticryoidectomy, and after dissecting the carotid oculomotor membrane or the opening of cavernous sinus. Something is affect to the blood circulation of the optic nerve, even after opening optic sheath sufficiently. So now, with this result, we stop to clip the aneurysm, paracrinoid aneurysm, as a first choice, especially medial projecting C3 aneurysm, so-called carotid cave. We stop. We just choose the superior projecting carotid ophthalmic aneurysm, the elevating the optic nerve. We try to do a neck clipping, but the small aneurysm, medial projecting, or in the cavernous sinus aneurysm should be the observation. Observation is the first choice. If the patient has the strong anxiety, even after our meticulous informed consent, the intracavernous aneurysm has the no risk or very, very rare rupture rate. But even such a explanation, some patients have a very strong anxiety. We recommend endovascular treatment coiling for such a patient.
ありがとうございました。
いえいえ、ありがとうございます。
We have two more hands, Dr. Ricardo and Dr. Ahmed. Please ask.
Okay, can I go here? Can I go? Okay.
Yeah.
First of all, thank you for the wonderful lecture, Professor. It's very inspiring. You show us very difficult case with some kind of technical skill that we can only dream, I think. I want, as a young neurosurgeon, I would just want to ask you one thing. During the lecture, you mentioned that closing the dura under the microscope, it's a good training to improve anastomosis skill. Any other suggestion about that, if you have got, and what do you think about using a model animal, using artificial model to improve these abilities? Thank you.
Yes, of course, to have an off-the-job training using animal, using artificial tube is effective, of course. But the most important thing is daily surgery, daily craniotomy. The macro manipulation without microscope. Without microscope, the stitching dura, stitching skin, stitching area, exactly and beautifully close the wound. It's a basics of surgery, not only neurosurgery. The ugly wound, terrible. If in my institute, if the patient have an ugly wound, I order the surgeon to reoperate immediately. So we must try to close the wound beautifully as it was preoperatively. And as I told you in the presentation, the most good training is dural closure and separating sylvian fissure or interhemispheric fissure bloodlessly, sharply, with the highest magnification. If you become familiar under highest magnification and you can control your hand fingers under the highest magnification, you have a sufficient skill to do a stitching the vessels. So daily surgery is the best training for you. I emphasize every day to my colleagues.
Thank you very much.
Yeah, welcome.
Professor Ahmed Fawad, please.
Okay, thank you very much. Thank you, Professor, for your nice presentation. I would like to know your advice and recommendation about a case. It was a 32-year female posterior facial hemorrhage, and unfortunately in Afghanistan, no surgery and endovascular neurosurgery available. The patient's condition is better now, but she is still complaining of headache, and would like to know about the like our condition with limited resources in Afghanistan. What's your advice for how to deal with like this patient? Thank you, sir.
I'm sorry, I couldn't hear you.
多分アフガニスタンのようなそういう途上国の若い医者たちがどうやって、そういうトレーニングをしたらいいのかと、血管内もないし、そう高価な機械もないし、と思います。
It's a difficult question. But in any environment, you need to perform the craniotomy in some patient. So, as I told you, the micro manipulation like the Sylvian fissure dissection or microanastomosis are based on the macro manipulation without microscope. So the macro craniotomy is a very good training for young guys. And just one point, the exact surgical manipulation, the making incision, complete hemostasis in every step, and then it makes young guys sure to perform the surgery. So yeah, depends on the environment. Of course, we need a good instruments, good microscope, but in any condition, we can improve our skills in daily work. It's my opinion.
Thank you. Thank you. Arigatou gozaimasu. Arigatou.
Welcome.
So I think, are there any more questions, or should we proceed for our next speaker?
Yes.
Okay, thank you, Professor, for such a wonderful talk and enlightening us with the concepts. So I would like to invite our next speaker, Dr. Kento Sasaki, who is a third-year neurosurgery resident at Fujita Health University Hospital, Bantane. He will be speaking on use of CFD in predicting morphological changes of the vessels in unruptured aneurysm near the aneurysm. So I would like to call Dr. Kento Sasaki to present his presentation.
Hello.
Yeah. Hello, Dr. Kento.
Can you hear me clearly?
Yeah, we can hear.
Okay. So I'll share my presentation. Can you see the presentation page?
Yes, we can see.
Hello, I'm Kento Sasaki, a 6-year postgraduate senior resident from the Department of Neurosurgery at Bantane Hospital. I'm going to present prediction of the morphological changes on the vessel walls adjacent to unruptured cerebral aneurysms with computational fluid dynamics. Background. the treatment of unruptured cerebral aneurysms has recently become more popular with catheterization as opposed to conventional craniotomy clipping, and the indications for treatment are expanding. CFD analysis of unruptured cerebral aneurysms has been reported to be useful for preoperative blood flow assessment and treatment strategy. So, when unruptured cerebral aneurysms were treated by direct clipping our hospital, there are cases of microaneurysms and thinning of the wall in the patient apparent artery adjacent to the aneurysm, contrary to what was expected on the preoperative images. Therefore, we compared intraoperative findings with CFD analysis to determine predictive factors for cases in which the direct approach was preferable. Methods. The time period was 2 years from May 2020 and included a total of 89 patients with unruptured middle cerebral artery aneurysm treated by cranial clipping at our institution. 94 aneurysms in total, 89 of which were circular and could be adequately observed intraoperatively with CFD data. CFD analysis generated on the basis of preoperative CTA shows that first, collision of the streamline with the outer parent vessel wall of the aneurysm. Second, radiation outwards from the wall of shear stress vector from the same site. And third, increased wall pressure compared to the surrounding area. The above three findings were defined as parent artery radiation sign pulse, and those with pulse in the CFD analysis were extracted and compared with the actual intraoperative findings. This is patient selection flowchart showing the 89 cases with 94 aneurysms, of which 25 cases with 25 aneurysms and 58 cases with 62 aneurysms remained as pulse positive and pulse negative cases, respectively, due to the shape of the aneurysm, missing CFD data, or insufficiently intraoperative observation. The table shows comparing the intraoperative findings and CFD analysis of 87 aneurysms. A total of 9 of the 89 aneurysms had a microaneurysm in the parent artery, of which 8 were pulse positive. 57 of the 87 aneurysms had no external surface changes in the parent artery, of which all were pulse negative. Result, 82 patients were aged between 41 and 87 years, with no significant difference in age, sex ratio, or mean size of aneurysm between the pulse positive and negative groups, respectively. 25 out of the 87 aneurysms, approximately 30%, had a pulse. 25 of the pulse positive cases had a microaneurysm in the parent artery consistent with pulse. In the pulse positive cases, 8, 7, and 10 aneurysms showed microaneurysm formation, integration with mass, and wall thinning, respectively, consistent with pulse, of which 92% or 23 cases required additional clipping or coating. In 5 cases, the vessel wall in the pulse area couldn't be observed in detail due to inflammatory tissue or thickened arachnoid fabric. In 62 pulse negative aneurysms, only 5 cases showed morphological changes in the patient parent artery. The prevalence of microaneurysm formation in the parent artery adjacent to the aneurysm was about 10%. Pulse positivity for the presence of a microaneurysm had a sensitivity of 89% and a specificity of 78%, while the presence of either a microaneurysm, integration, or wall thinning had a sensitivity of 83% and specificity of 100%. Representative cases are presented below. Case 1, 44-year-old male, right MC aneurysm. The top left is the streamline. The top right is the wall shear stress vector, and the bottom left is the wall pressure. Each of them, as if encircled, shows a streamline impingement, radial dispersion of the wall shear stress vector, and an increase in the wall pressure. Intraorbital findings shows the formation of microaneurysm in the area coinciding with the pulse. It was treated with additional clipping and coating. Second, 71-year-old female, left MC aneurysm. The streamline impingement, radial dispersion of vector, and elevated wall pressure were observed in the encircled area. Intraorbital findings show the reddish change in the area coinciding with the pulse compared to the surrounding area and the suspected worsening. It's treated with additional clipping and coating as well. Third, 74-year-old male, right MC aneurysm. The pulse was found in the parent artery in the area of the enclosure, and the intraoperating findings show that the area consistent with the pulse was part of the aneurysm. It was also treated with additional clipping and coating. 77-year-old female, right MC aneurysm. The area surrounded as if it were pulse. Intraoperative findings were light, showing formation of a microaneurysm matching the pulse. The patient was treated with additional clips as well. 70-year-old woman, right MC aneurysm. Similarly, the circled area is pulse. Intraoperative findings show the formation of microaneurysm consistent with the pulse, as shown in the lower right-hand corner. Yeah, the patient was treated with additional clip as well. Discussion. There have been several reports of findings that predict wall irregularities in the aneurysm itself, but this is the first study we have been able to access that focus on the extra-aneurysmal vessels. The fact that morphological changes in the parent artery, which couldn't be predicted by preoperative CT alone, can be predicted by CFD analysis in the presence of pulse, may be useful in planning treatment strategies for unruptured cerebral aneurysm in the future. In addition, the external surface findings, including the microaneurysm, were minimal and may have been difficult to treat with endovascular invasion. So there are also some limitations, such as lack of DSA examination and the fact that in some cases with small vessel CFD analysis is expected to be difficult. Conclusion. The need for direct confirmation of the structures around the aneurysm with a direct approach when pulse is present on preoperative examination is suggested. Thank you for your attention. That's all.
Thank you. Thank you for the wonderful talk. And now, can you close your slides?
Thank you.
Yeah. Thank you. Thank you, Dr. Sasaki. So the platform is open for the questions. And first, I would like to ask a few questions. This is an interesting study, and the application of CSD, it has gone beyond the aneurysm. Now we are predicting the futures. Last time when I went to Japan, then when professor showed the application of CFD to predict the probability of rupture of the aneurysm or how to observe cases depending upon the condition of the aneurysm based on CFD. So the questions are, I have few questions, like based on this, do you apply this regularly in on regular cases for to decide the type of clipping? And based on this, can you decide whether we should go for open surgery or we should go for endovascular treatment? Because the vessel wall is different. Should we go for stenting or flow diverters because there is probability of new aneurysm formation, or we should go for clipping? Have you ever thought?
Thank you. Actually, in my institution, we prefer direct surgery because of our boss is a clipping specialist. But if we find a past sign, maybe it's better to see direct surgery for in case with microaneurysm or something. But actually, we didn't perform DSA before operation. So maybe in DSA examination, we can find some micro changes in endovascular. I don't know.
Okay, like Professor, can you, Professor Kato, can you elaborate, like with the help of this study, like whether to choose flow diverters? Because if you are finding that there is chances of microaneurysm formation, so should we go with the stenting or flow diverter, or should we proceed with extra clipping? Because at that time there was no aneurysm, but there is probability that there will be some aneurysm formation.
Yes, thank you very much. So this is the Kento that he found. So this phenomenon, I think it's great for him, I think. So according to his the result, I think maybe in the future, maybe this is kind of the making a decision, open or endovascular.
Yeah.
But the very tiny aneurysm, maybe we can observe, but I think the larger one, maybe we can have the clip is, I think, a good for treatment, I think. 鈴木先生、鈴木先生いいですか？
はい、ありがとうございます。
One more thing is that this is one suggestion. Like if you are finding that there is chances of aneurysm formation at this point, and rather than observing, you can go for surgery and wrap some muscle patch over the probable site of new aneurysm formation. That might change the vectors and the wall strength during the same surgery. Did you get my point?
Yeah. Usually, we check the CFD from M1 to M3 or something for MCA aneurysm. And sometimes we find a plus sign in other place like M2-3 bifurcation, something. At that time, we try to observe some parts apart from the aneurysm. And if we see like thinning or something, irregularity, we treat, of course, including clip or wrapping or something. Yeah.
Thank you. Thank you, Doctor. So any other questions?
Yeah, I think Dr. Jankovic, yeah.
Hi, good afternoon to all, Professor Kato. Hi, Professor
How are you?
And all other friends. I have just a comment. That's a very, very interesting study, and I have one question about study design. Did you measure just wall shear stress, or did you use also oscillatory shear index? Well, because it's very interesting to see also pressure difference and oscillatory shear stress according to the these two parts group. It will be very interesting in study that to see.
Thank you for your question. Actually, in my institution, we just see 4 parameter, wall pressure and wall shear stress vector and wall shear stress the number and streamline. And nowadays, I just can become search OSI or something, but this 1 year before, so this research started before that. So actually, I didn't use that, but the most important parameter is wall shear stress vector, I think. So in my opinion, I don't need other parameters. Yeah, apart from wall shear stress vector, maybe.
So thank you very much, Dr. Dragon. So you'll be coming to our institute from next February. So we are all awaiting your arrival. Thank you so much. So I think high OSI is very correlate with the theme wall for the future rupture. I think we should include OSI. OSI is one of the most important parameter. So far in our institute, we cannot measure. So once you come, maybe we will include such an OSI. Okay, so you can study.
Yeah, thank you.
Thanks so much. Thank you. Aishu?
Yeah, Professor. So any other questions?
I would like to ask one question, Dr. Ishu. Dr. Sasaki, it was an excellent research topic, actually. It's like primary prevention for aneurysms. So I think I just wanted to know your inputs on aneurysms, apart from MCA, for example, supraclinoid aneurysms or supraclinoid IC aneurysms, or for example, anterior cerebral artery aneurysms. Have you seen any difference? Have you done some study in the non-MCA group as well?
Actually, in my hospital, we usually try to check the CFD in any aneurysms, and sometimes we find the pulse in ICPC aneurysm or something, but the depth and angle makes difficult to observe. So now we having a new endoscopic something. So after getting that, maybe we can observe more better. So yeah. And
thank you so much.
Yeah. And the point of
probably because yes. Sorry, go ahead.
Yeah, easy to see. I choose MC aneurysm only. Yeah. That's it.
Thank you.
Thank you, Ashish.
So it was a very wonderful presentation, and new ideas have been generated because it's a new concept. So maybe Dr. Sasaki, you can take these ideas and incorporate in your study, because it's a very relevant and futuristic study.
Yeah, thank you.
So I think, are there any more questions? There is one question in group that is from Dr. Kabibullah. Is for you, is there any difference between aneurysm and aneurysm coiled before and expected to be clipped? So the question is like the Dr. Kabibullah asked that was there any difference between aneurysm coiled and now again aneurysm formed, and is there any difference between aneurysm and aneurysm was coiled before and expected to be clipped? Mm-hmm. Did you read? I should ask Dr. Kabibullah to directly ask his question. Let's see. allowed to talk. Dr. Khabibullah. Hello. Dr. Khabibullah.
Hi,
Yeah, you can directly ask the question.
it's clear now.
Yeah.
I wanted to ask about differences, just aneurysm without, which is not treated before, either by endovascular coiling or by clipping, and the aneurysm that has been coiled inside the coil and no coil.
With the use of CFD, you wanted to know the
Yes.
difference. Yes. So
Okay.
did you get the question, Dr. Sasaki?
Yeah. For making CFD analysis, we need accurate data of vessel images. So, like CT angiography, in CT angiography, if the patient has already coiled, the images have some artifact. So not exactly images are made. So maybe it's a little bit difficult for recurrent aneurysm or something.
So Dr. Habib, it was a very good question. I think just you can make such image before treatment. So maybe as a simulation. So the before stenting or after stenting, how the decrease of the flow, the streamline in the such as a cavernous, the large aneurysm, something like that. So I think after the coiling or after clipping, it's very difficult to create such a CFD image, I think. Habib, is it okay?
Yes. Thank you, Sensei. Is that okay?
Habib Sensei, it's now in Nagoya University, the clinical fellow. Thank you, Habib.
Thank you, Sasaki Sensei. It was clear, a good presentation. Thank you very much.
Yeah.
So we can conclude that, and there were very wonderful presentations from both of the speakers. So now we can finish our webinar. Professor Kato, do you want to say, ma'am?
No, it's fine, I think. So maybe Dragon, and you understood how the Japanese is important.
And I learned Japanese. Okay? I learned Japanese.
Okay, so now Kapil, who is with us now, he can speak Japanese day by day. So he learned the Japanese.
That's good. That is good for his brain also.
So both speakers, it was the excellent lectures that we satisfied so much. Thanks so much.
Thank you. So, arigatou gozaimasu. Bye-bye.
Who is the next, your daughter?
No, ma'am, she's my wife.
Sorry.
She's really tired of the webinar.
Thanks so much. It was a nice webinar. Bye-bye.
Yes.
Arigatou.
Oyasumi. Arigatou.